Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a primary ovarian mucinous carcinoma. This is a case of a 34-year-old female patient who presented with right ovarian mass that was really large, 11 centimeters in maximum dimension, and unfortunately, it was removed in pieces. So on low power magnification, as you can see, there is an expansile growth pattern of variably sized glands with stratification of the lining cells as well as atypia. Now, the size of this focus on low power magnification was exceeding 5 millimeter in one dimension, which really qualifies for the expansile pattern of invasion in mucinous carcinoma. Now, on higher power magnification, as you can see, the glands are lined by atypical cells with stratification and scattered goblet cells here and there. There is another focus where we have more of the dilated glands, the stratification of the nuclei, cigar-shaped nuclei, as well as the goblet cells scattered throughout the epithelium, which means that we have intestinal type of differentiation or proliferation of this mucinous tumor because of the expansile growth pattern of the mucinous carcinoma in this example. Now, the question would come here whether this is a primary or secondary metastatic to the ovary. Remember, this is extremely important to answer, and sometimes immunohistochemistry might be of help, sometimes it is not. Let's see what happened in this particular case. So cytokeratin 7 was strongly diffusely positive throughout the tumor, which in a way would favor slightly that this is ovarian over, in particular, lower gastrointestinal tract tumor, although an upper gastrointestinal tract tumor might, of course, be cytokeratin 7 positive. Now, cytokeratin 20 is also positive, and here comes a little bit of the confusion, where really the lower gastrointestinal tract, the colon, as well as the appendix, as well as even the upper gastrointestinal tract metastasis, for example, from the small bowel, can get strongly into the differential diagnosis. CDX2 is also positive, showing the nuclear staining in the tumor cell nuclei lining the glands. So using cytokeratin 7, cytokeratin 20, CDX2, we're not quite sure whether this is a primary ovarian or metastatic gastrointestinal carcinoma. Now, what about SATB2? SATB2 is completely negative in the tumor cell nuclei. I've had here in the insert the control, the appendix. We use control, the appendix as control, and as you can see, it's really, our stain is working beautifully, showing the strong nuclear positivity in the appendiceal normal glandular lining, whereas in the tumor cells, the tumor cell nuclei are completely negative. And it appears that a combination of positive cytokeratin 7, negative SATB2 nuclear staining are the best combination of immunohistochemistry to favor the diagnosis of a primary ovarian mucinous tumor, in this example, mucinous carcinoma. What about PAX8? Now, in this particular case, PAX8 was positive, but this is unusual. It's only positive, PAX8 is only positive in 30% of a primary ovarian mucinous carcinoma, and this was actually one of those cases. So we have now a strong evidence between cytokeratin 7 positivity, SATB2 negativity, and PAX8 positivity to support that this is a primary ovarian mucinous carcinoma. ER in this case was completely negative in the tumor cell nuclei, whereas it was positive actually in the stroma, in the ovarian stroma in the background. So the final diagnosis in this case is a primary ovarian mucinous carcinoma. This is showing expansile growth pattern where the dimension of the focus of the complex growth of the gland exceeds 5 millimeter. And as I alluded to initially, because the tumor was received in fragments, probably this is the result of surgical fragmentation or surgical spell. The case was assigned as a FIGO stage 1C1. Remember that when you ever encounter a mucinous carcinoma in the ovary, whether this is showing an expansile growth pattern, as in this case, or an infiltrative growth pattern, regardless of the growth pattern, you have always to consider metastasis from the gastrointestinal tract, mostly from the lower gastrointestinal tract, but all, including the appendix, but also from the upper intestinal gastrointestinal tract, including the pancreaticobiliary system, as well as the small bowel, which is frequently overlooked or forgotten when we start our differential diagnosis. A combination of cytokeratin 7 positivity, SATB2 negativity, and in the lucky cases, in only a third of the cases, PAX8 positivity would really support the diagnosis of a primary mucinous ovarian carcinoma. I hope you find this tip useful in your daily practice. Thank you.